I have the privilege of introducing him. He's a good friend of mine for several years. We've collaborated in the past, so thank you for that. And Dr. Vahidy is an associate professor in the Department of Neurosurgery and the Neurological Institute at Houston Methodist, in which he co-directs the Center for Health Data Science and Analytics. He also holds the inaugural Centennial Endowed Directorship in Quality and Outcomes. He has over 100 peer-reviewed publications on ICH outcomes and recovery research, and more recently for patients with neuro-COVID. Dr. Vahidy.
Thank you so much, Dr. Ahmed, for that introduction, Dr. Volpe, Dr. Garg, for the invitation to speak today. It's always nice to be standing between the audience and a lunch break. So I'll try to make this interesting enough and worth your time. Thank you for being here, who are here in person and those who are attending remotely. It's a very nice segue, I think, into my talk. You all have heard these fantastic reviews about how ICH patients are managed in the critical care by our neurocritical care colleagues and the guidelines. I would like to remind two things from the last talk. There are no class 1A or class 1B evidence for treating ICH patients. And the last point, that quality of life is important. And that is a really nice segue into my talk, actually. These are my sources of funding. I have no disclosures and no conflicts of interest as far as this talk is concerned. The objectives are fairly straightforward. I would like us to understand the key components of what patient-centeredness is as far as outcomes research is concerned. I hope that after my talk, the audience would be able to exemplify some clinical problems in cerebrovascular disease broadly and ICH more specifically that warrant a patient-centered approach, and define what quality of life is and what health-related quality of life is more specifically. And then maybe comprehend the underpinnings of direct and indirect measures of quality of life as they pertain to patients with intracerebral hemorrhage. This is a session on intracerebral hemorrhage. Very happy that out of 6 sessions, at least 1 session is dedicated to ICH. Just to review, the disease we are talking about, or the disease that I'm referring to mainly in my talk, is the parenchymal bleed of the intracerebral hemorrhage, not the other kinds of intracranial hemorrhages. The primary etiology of the parenchymal bleed, very broadly speaking, is either hypertensive or is amyloid driven in different patient populations. Not going into a whole detail of that, but I do want everyone to think about that 30 to 50% of ICH patients even today face a 30-day mortality. So that's a really high mortality for a disease. And furthermore, more than 80% of survivors are left with a certain degree of impairment. That is, they are unable to go back to their pre-ICH functional status. So it's a disease with a very high level of mortality and morbidity. It disproportionately affects certain population groups. We have done some population level work recently. One of my postdocs is here, and we have actually shown that the actual population level incidence of ICH is rising, not just the hospitalizations, the actual incidence. And again, just to drive home that point over and over again, there are no definitive 1A and 1B evidence-based treatments for ICH. So what is patient-centeredness? Well, the idea of patient-centeredness is that it entails the evaluations of questions and outcomes which are actually meaningful and important to the patients and their caregivers. Remember the 10th tenet of the ICH guidelines, patient and caregivers and their quality of life, and that's where we are bringing it together. The idea is that patients and their family members can actually provide unique perspectives to change and improve the pursuit of clinical questions, how these clinical questions are framed, how are they addressed, and how are they evaluated. But why can't the researchers and clinicians do it, right? Well, they can't do it because what has been demonstrated that experiences and training shape a person's view of the world. And that intrinsically biases us to start thinking in ways that might be deviant from how patients and their caregivers are thinking. And also, we know that there are dogmas in clinical practice and clinical research. And the whole field of evidence-based medicine has been developed to fight those dogmas, but we face those dogmas on a daily basis. So that's why patients' view and patients' perspectives are important. In the United States, especially, patient-centered research has primarily been funded by an institute, which I'm sure most of the audience would have heard about. It's called Patient-Centered Outcomes Research Institute, or PCORI. PCORI came into existence, was a very smart move, one of the better moves in the Affordable Care Act, not here to make a statement, but it was established in 2010. And it was actually not technically federally funded. It was funded from fees assessed on private and self-insured healthcare plans. 2019, there was a big debate whether PCORI funding should be continued or should not be continued. It is going to be continued till 2029, at least in the range of about $275 to $400 million annually. Thus far, PCORI has actually funded $4 billion of research across some 2,000 projects, of which 500 have been completed, and their results are actually on the PCORI website. There is a specific stress on patient-centeredness as far as PCORI is concerned across the spectrum of research. So finding the right questions, designing the questions, selecting the outcomes, implementation of research, and of course, patient engagement. A quick example, like for an asthma trial, if the outcome is FEV1, which is a forced expiratory volume within a certain time unit, those kind of trials don't get funded by PCORI. But if we add the outcome, say for example, what is the parental report of asthma control, that is what PCORI is more interested in. The other agency that funds patient-centered research in the United States is AHRQ. So moving on to the quality of life aspect of the patient-centeredness and what is quality of life. And bear with me, this discussion might go from a very highly clinical discussion or talks that you were listening to more of a philosophical discussion, because quality of life is a partly philosophical concept. So how WHO describes or defines the quality of life is, and this is a mouthful, but I have highlighted some of the important concepts here. So it is the individual's perception of their position in life in context of the culture and value systems in which they live, in relation to their goals, expectations, standards, and concerns. So it's a multi-dimensional construct. It's not very easy to measure it, as I would be showing in the latter part of my presentation. It is a broad-ranging concept affected in a complex way by person's physical health, psychological state, level of independence, social relationships, and their relationship to salient features of their environment. So breaking it down further, it entails a lot of things. It entails a person's emotional well-being, their psychological well-being, their social roles and social well-being, and of course, their physical health and functioning. We tend to usually focus on the last part of this bullet list. Like, what is the physical health and what is the physical functioning? And most of the outcome measures that we see in the field of cerebrovascular disease or stroke, ICH, are mostly focused on how good a person is performing physically. Look at the MRS that we have used for decades. MRS just focuses on a functional state. And we tend to assume that a person with MRS2 is going to be better than an MRS of 3 because they are functionally better. But it does not take into account the context in which that functional state exists. And that's where some quality of life measures come in. All right, so what about health-related quality of life? Of course, as the name implies, it allows the individuals to implicitly weigh aspects of their health according to their own personal values. And these own personal values is a very individual construct. Each one of us sitting over here have a different value system, which is very individualized. And how we assess our well-being within that framework of that value system is going to vary individually. So some who have worked a lot on health-related quality of life consider that it is a gap or a mismatch between expectations and experience. So what is an expectation? Expectation is a set of stabilized assumptions to inform our standards. And notice that I have highlighted stabilized, which means that expectations change over time. And so what our expectations from our environment for ourselves are today might be different at some other point in time. But at any given point in time, it is a stabilized set of assumptions. So if the expectations roughly equal the experience, then most people will say that their health-related quality of life has had no or minimal impact on it. But however, if the expectations were higher than the experience, then one can experience a low health-related quality of life. So it's a very sort of simple mathematical way of looking at a more philosophical concept. And expectation, as I said, is fundamental to one's identity, which is influenced by several factors. It's influenced by social class, age, sex, race, ethnicity, sexuality, disability, personal biography. It's truly a product of one's identity. So the expectation experience paradigm, if we are to build on this, it imposes several measurement challenges. So poor expectations with low levels of, poor experience with low level of expectation would lead to no or minimal health-related quality of life impact. But the issue is that expectations will also change over time. And at least in part, our experiences are also shaped by expectations. So it's complicated and it's not easy to measure. And in the interest of time, I won't spend too much time on the challenges, but there are several challenges that have been described in measuring these health-related quality of life. And they are really very interesting, few of them that I would like to touch upon. The first one is called the disability paradox. And what the disability paradox is that it is very well documented that there are certain individuals with really high levels of permanent disability who end up rating their quality of life much better than the general population. Another example of problem is something that's called response shift, and it has specifically been studied in patients with renal transplant, right? So what has been done is that patients who are on dialysis and are waiting for renal transplant, their quality of life has been assessed, and there's this one study in which it turned out that it was 5.3. These patients are getting daily dialysis and quality of life is really impaired and they are waiting for a transplant. Now post-transplant, of course their quality of life as expected improved to 7. But when after transplant they were asked retrospectively about their quality of life pre-transplant, now they said it was poorer than when they were actually going through it. What is inbuilt in all these phenomena is the phenomena of human resilience. The phenomena of human resilience is really important. And sometimes we as researchers or as clinicians underestimate how much resilient our stroke patients are. And that's where I'm going to lead you to think about when you think about stroke patients, when you think about their outcomes. I'm going to skip over the rest of them. Patient versus proxy assessments is an issue. Not all health-related quality of life measures are patient-centered, so we need to think about which ones are patient-centered. And then, of course, there is a lot to be said about whether the instruments are valid and responsive, and we need to be thinking about those aspects. Broadly, there are two types of methods that are defined for assessing health-related quality of life. There are direct methods and there are indirect methods. The two main direct methods are standard gamble and time trade-off, and there's a list of indirect methods, of which EQ5D or Euroqual 5 dimension is the one that is most commonly employed. I'm going to introduce the EQ5D as an example because that's the one that has been most avidly studied and we have a lot of data from that. And then I'm going to end my talk by talking about standard gamble, which is a direct measure. So the difference between direct and indirect, so if we look at the two direct methods, time trade-off and standard gamble, what happens in time trade-off is that the respondents express an indifference between, say, 10 years with a specific health condition or a period which is smaller than 10 years in a perfect health. So they are asked to balance this time trade-off, that you can either continue to live in your present state of health for 10 years, or what would you prefer, shave off some time from 10 years, but that smaller amount of time you would actually continue to live in a perfect state of health. And that's how the health utility is determined. A standard gamble, I'm going to talk in a little bit more detail, so I'm going to skip over in this slide what standard gamble is. But let's look at the indirect side, where, say for example, in EQ5D, patient in a certain health condition fills a questionnaire, and those responses are then measured against certain population level coefficients, and a quality of life index is then achieved. So what that quality of life index is, it's usually a number on a scale of 0 to 1. 1 indicates that a person has a perfect quality of life, and 0 essentially indicates that a patient is indifference between living and non-living. So that's how the scale is measured. There is a very good review by Matt Reeves and colleagues from Michigan about quality of life scales in stroke. The reference is here. Essentially, they talk about all the types of measurements that have been studied and their properties. And as I said, the most studied is what is EQ5D. And very briefly, what EQ5D does is that, I wonder if the mouse would work, yeah. So it is 5 measurements, 5 dimensions at 5 levels. Mobility, self-care, usual activities, pain, discomfort, anxiety, and depression. And a patient states what level they are at. And then, as I said, this score, based on certain population-based coefficients, is converted into an index which determines a person's quality of life. So that's the basic premise behind EQ5D. Let's move to standard gamble. So a standard gamble is considered a gold standard in making direct quality of life assessments. And a decision is made under a state of uncertainty. And that's why it's considered a gold standard. The gamble is between perfect health for a given amount of time and immediate death, or a certainty of living in an intermediate health state between perfect health and death for the same amount of time. So that if the perfect health is P, then the probability of perfect health is P, then the probability of death is 1 minus P. So the value of P is varied until the individual is indifferent to choose between the gamble and certain intermediate health state, at which point the P is the utility of certain intermediate health state. I know this is very complicated, and that was the challenge. Our challenge was that would ICH patients who are maybe intrinsically cognitively impaired, and there is a question of capacity, and there is a question of capability, would actually be able to understand this assessment. Let me try to explain it in a slightly more simpler way. So what is told is that a patient is approached and a hypothetical situation is proposed to them. And that hypothetical situation is that let's suppose we have some magic pill, and we can give you that magic pill, and few things can happen after that, right? So that is the alternative one. That are you going to take the magic pill, or do you not want to take the magic pill, and are you going to stay in your continued state of health? What do you choose? The choice is made for the magic pill based on what is the likelihood, what is the probability, what is the chance of a perfect state of health. So we usually start by saying that, let's say I have a magic pill in my hand, and I'll give you this magic pill to take at night, and in the morning you're going to wake up absolutely healthy. And there's 100% chance that in the morning you're going to wake up absolutely healthy. Will you take this magic pill? Most logical people will say, yeah, sure, we will take the magic pill. But the learning that we had from this experience was phenomenal, because honestly, some people tell us, I don't believe in magic, I don't believe in miracles, and I'm not going to take the pill, right? And that's fine, and that's fine. That's what we wanted to learn. But that's where we start. So most people will say, yes, I will take the magic pill. But then we say, okay, what if you take the magic pill, there are 98% chance that you're going to wake up in perfect state of health, but there's 2% chance that you would peacefully pass away in your sleep. Would you still take it? And that's when you start assessing how much a patient truly values their current state of health. And that's the direct measure, and that is the true gold standard of measuring quality of life. So this sliding chance is what I mean by the 98%, 2%, 90%, 10, and then we keep on sliding. If someone says, yes, I'm willing to take that 2% chance of peacefully passing away in my sleep to gamble for a perfect state of health, we'll say, well, will you take 5% chance? Will you take 10% chance? And that determines the probability. If someone is willing to take 5% chance but not 6% chance, then their quality of life is indexed at 0.95, right? But if somebody is willing to take a 90% chance or is willing to accept a 10% chance of getting better and 90% chance of passing away in their sleep, their quality of life is 0.1, right? So we, actually in collaboration with my colleague here, Dr. Ahmed at UT, we designed this ERIC study. Did I just got bumped off? Let's see. No? I don't know. Okay, so what I'm going to say, we designed a study, and what we were doing at UT is that we were enrolling ICH patients from 5 different cities across the state of Texas. And actually the rationale behind this study was to study the number 1 2022 recommendation about systems of care. So we were looking at different systems of care, and we were seeing how patients are transported or transferred across those systems of care, and what goes into clinical decision making of transferring ICH patients from like smaller hospitals to larger hospitals, and so on and so forth. So that is the Enrich study. In BMC Neurology, we have the protocol. Somehow the slide crashes the presentation. So that is the study, and then within that, what we did was, I guess they are working, I wouldn't double click. Within that, what we did is that we said, okay, as a part of this study, we are also going to assess a standard gamble on ICH patients. And what I want to demonstrate, maybe I should just move the slide forward real quick. Okay, and that's the article for where we did the standard gamble, and it crashes. Anyway, so if you pull up the article, if you have a device, or if you do it later, we ended up assessing good amount of 500 ICH patients at different centers, which people who do ICH research would appreciate. That's a big number of patients. For standard gamble, we demonstrate that up to 70 to 80% of the time we were successfully able to administer a standard gamble in ICH patients. The most interesting part in my presentation, and I think that's the reason why this is crashing, is a video of one of our research coordinators assessing a standard gamble examination on Jim Grada. And people in this audience would know who Jim Grada is. Jim Grada is probably a person who has one of the most, if not the most, experience of seeing stroke patients and evaluating stroke patients and treating stroke patients. And it is very interesting to see that we told him that consider a patient with an MRS of 4. For those who don't know, MRS of 4 means that a person is very highly dependent for their activities of daily living. They are not completely bedridden, which is MRS of 5, but they need a lot of assistance in coming out of the bed and in taking care of their activities of daily living. And we asked him that we are going to administer a standard gamble on you, and you assess in your mind what valuation would you put on your life if you had an MRS of 4 after stroke. So there is a video that got published with the publication, and I'm certain that's crashing the presentation today. But that's here, and it was very interesting to see where he placed that valuation and the data that we obtained from those 500 patients, where an average person with an MRS of 4 placed that valuation. And I'll spill the beans. Jim Grada placed that valuation at around 0.1, where he thought that a patient with MRS of 4 who is almost bedridden, sometimes incontinent, heavily dependent, would be taking a 90% chance to obtain that perfect state of health, 90% chance of dying peacefully in their sleep to obtain that perfect state of health. Our data demonstrated that that valuation from stroke patients is 0.95 at an MRS of 4. And when we looked at the literature, though not a whole lot of work has been done on it, one of our colleagues, Andrew Barreto, ran an argatroban trial. And on a small number of patients, he also did the same experiments. These are about 80 ischemic stroke patients. And the results are very similar. For an MRS of 4, the health utility that we get is in the 90s, which means that on the average, an ICH patient who ends up with an MRS of 4 at 90 days, who we as researchers or the community or clinicians would consider a pretty compromised state of health, the patient values their life and the patient values their health in a very different way. And that is the message that I wanted to convey today with the rest of my slides. And I think this is an extremely important aspect of patient-centeredness that we should keep in mind when we develop research, when we design research, when we take care of our patients, and even when we consider, because sometimes I have heard colleagues saying that, yeah, we reduce mortality, but the functional outcomes are really poor, right? And we are not the ones as clinicians and researchers to make that value judgment. And maybe reducing mortality is really important, because we are not to decide for patients and their caregivers their functional status and the valuation that they put on their functional status. I will end I think my time is up. Sorry for the little, but the video that I wanted to share is published, so please look it up if you are interested. Thank you so much.